I have a great pleasure to talk to Dr. Cyril'em Evian'em, and we're gonna talk about the immediate implantation. Could you tell us what rules should we follow to get a success in immediate implantation?
You mean generally speaking, in any specific sites? What do you mean?
Generally speaking, just to give some tips for young implantologists, especially.
All right. If you're working, I'm going to talk about the anterior zone. In the anterior zone of the mouth for immediate placement, if you want to try and preserve mainly aesthetics, soft tissue, I would suggest you place the implants, smaller diameter implant, more towards the palate, so that you leave yourself enough gingival tissue and maybe a bone that may resorb slightly, that it doesn't resorb as far as the implant. And then I also use bone in these sites to make sure I don't lose too much of the facial aspect of the bone.
So how should we determine the width of the implant, the diameter?
Well, I would say in the region of 3.5 to 3.8 millimeters, if that's a possibility. If it's a lateral incisor, you may be speaking in terms of a 3.4 millimeter. A canine you could stretch to a 4.5, but I think a 3.5, 3.8 in the central incisor is as much as you want to go.
Mm-hmm. And what do you think about the short implant? It's a good solution for especially lower jaw when we have a lot of times deficiency of the bone.
I think you're talking about an 8 millimeter implant?
Or even 5?
5 I find short, but if you can stretch it to an 8 millimeter implant, that's acceptable in many cases. Because as we know, a lot of the stresses and strains is taken up around the coronal aspect of the implant. So I feel that would be satisfactory in a lot of these cases.
Mm-hmm. And what do you think about the areas when we do augmentation? So should we avoid bridges in this area on the implants and only make some crowns, so one implant, one crown?
Not necessarily. I think there are a lot of cases where bridges survive, and I think very satisfactorily. I mean, you could use 2 implants for 3 teeth, you could use 3 implants for 4 teeth, 5 teeth. So we use bridges often, especially when you consider the finances start increasing the more implants you use.
Mm-hmm. During your great lectures, you told us about the splinting the implants when we make, for example, bridges instead of separate crowns. What we can gain for the patient doing this splinting?
If you're doing full mouth cases and you are splinting the teeth together, if there's a possibility that as time goes on you may lose an implant, if you lose an implant in a splintered case, you still have clinical success. Whereas if you lose an implant in a situation where they're all individual, you really have to then replace that implant, the crown, the abutment, and so on.
Mm-hmm. And what do you think, how we should prepare the patient for implant therapy and for the full mouth reconstruction?
In what way? How do you mean prepare the patient?
We have the patient coming from the street, let's say, to our office.
Well, the most important thing is to make sure the patient is informed, understands what they need, understand the risks involved, and any problems that may occur, and give them all the information, and then they have to make their decisions.
Mm-hmm. And what do you think about the maintenance and about the taking care of the bite?
I think the maintenance goes without saying. Every patient should be maintained according to our normal protocols. If patients have previous history of periodontal disease or implantitis, they should be seen at least every 3 months. Patients who are resistant could be seen every 6 months. As far as about the bite? What was the question?
Yes, the occlusion.
Well, the occlusion has to be dealt with according to the needs of that particular case. Every case has its own needs.
Mm-hmm.
And its own requirements.
Mm-hmm. And nowadays, what do you think about the role of dental hygienist and the whole team?
Well, the hygienist plays the same role they've always played in maintaining and advising patients on the health of their mouths, and making sure that the patient comes back frequently and then is maintained frequently when they do come in.
Mm-hmm. And the last topic, different companies give, when they sell the implants, they give lifetime guarantee. What do you think this?
There's no such thing as lifetime guarantee.
Mm-hmm.
There's no such thing. If they're trying to tell you that they'll replace an implant when it's lost, that's fair. But there's no such thing as an implant lasting forever. I mean, you can't give that guarantee.
And what we can say to our patient if they ask for lifetime guarantee?
Tell them there is no such thing in human biology.
Mm-hmm. And what we can say to support the patient keeping the implants for the rest of the life.
The better you maintain it, the better chance you have. There are risks involved, underlying medical conditions, smoking, a history of periodontal disease are all risk factors, and patients should be made aware of that.
Mm-hmm. You mentioned also that important is the trust between the patient and the dentist, that if we find out that some chronic diseases should be taken care before the treatment, we should refer the patient to other specialists.
Well, if there's underlying medical conditions, they should always be referred to their specialist who deals with that the best, that specialist is able to deal with for the patient. And outside of that, if they're smoking, try and get them to stop smoking. And there are other underlying factors like history of periodontal disease, which you can't really change.